I think I'm not talking of the hydrodelineation or hydrodissection. And I started doing hydroimplantation for quite some time. So I thought lot more things can be done in the anterior chamber without putting the viscoelastic. So whether it's a management of the cataract or the IOL or the iris, anterior capsule, posterior capsule. So like uh, we have seen a lot of time these intumescent cataract where the rhexis runs away. So if you use the IM cannula and put on the infusion from one side, put the cannula from the other side and do the massage, the tension in the capsule will go. When you will do the capsular rhexis will never run away. So I've done hundreds of cases. Initially I used to inject the viscoelastic stain and then used to do this massage. Then the dye used to get really washed off, it used to come off, so the visibility used to be less. So now I do it under hydro and inject the air, stain this capsule, and then you will see that the even large rhexis you can make is going out, but it won't go out because the intralenticular pressure has been reduced in this patient. So this is another patient who had a absolutely glaucomatous patient, and again same thing done, did the massage, and you go ahead and do the rhexis. I mean a wider rhexis you can see is quite in the periphery which is going out, but it won't run away and you can complete the rhexis. So the toric IOL implantation, probably I was the first to use the toric IOL produced by the Star in the country. We used it for the thesis purposes. At that time I noticed the post-op rotation was where I used the methyl cellulose. So don't use methyl cellulose for putting the toric IOL because it cannot be completely removed from the capsular bag. Either use Helon GV or use the hydroimplantation. So the toric IOL can be easily implanted into the bag using only the fluid, maintaining the chamber from the side port with the fluid and place the lens inside the eye. And we know that because we can rotate the IOL clockwise, so these Johnson & Johnson lenses got a little roughened edge, so it does not rotate so easily. So if now I don't want to rotate this whole 180 degree of the IOL, I just put on a hydro and pull this lens from this side and then push it from this side and position it over there without rotating 180 degree, without using any methyl cellulose or Helon GV, so that I don't have to fill the bag, then keep on removing it, so taking another 3, 4, 5 minutes wasting over there. So these maneuvers can be easily performed inside the eye. I'm running, so this is the lens which opened wrongly. So now this is opened upside down. So just putting the infusion from this side, taking the repositor from the other side, flip inside the eye without putting any methyl cellulose or viscoelastic or Helon GV. You can just flip it over and then place the lens inside the bag. So I'm making the another side port incision. Well, normally I make only one side port incision. Then I take an instrument and just take it out and flip it over and place it over there. So there are a lot of things you can do without putting it over there. It saves. So this is dilated atonic pupil. After cataract surgery, you can actually finish off your cataract surgery, and then you can really try to hold with the aspiration cannula under the infusion itself and try to make the pupil as small as possible. So at least you can cover the edge of the IOL by just pulling them towards the center. Traumatic cataract, so just keep on pulling it. I was a little conservative, but actually you can pull it even more than this if required. And many times whenever we get the traumatic pupil and we want to do the pupilloplasty and iris repair, this technique actually helps you to identify whole of the iris where it is lying crumbled up, and you can really pull them and make it little smaller than what it was. So now it's little more acceptable as compared to what it was. At least it is covering the edge of the IOL. So there is a small capsular fibers coming to the posterior capsule. You just flush it with the irrigation cannula, and at least you can remove them from the center and will not disturb the vision of the patient. And particularly it becomes very important if you are going to put the EDOF lenses. So if there is anything in the posterior capsule in the central part, patient may have little blurred vision. So you can see this is 50 lens, you can see the reflex over there. And another important thing is whenever we use the B-hex or the Malugin ring, so we need to, for putting the IOL, we put on a viscoelastic and we want to remove the ring. So once we remove the ring, removing the viscoelastic from behind the IOL becomes very difficult. So I do hydroimplantation again, and even if you do and then after doing the hydroimplantation, I used to inject the viscoelastic for removing the Malugin ring and this pupil dilator. So nowadays I do not do that. I just put it inside and just detach it. Just take it out, and you don't have to really use any methyl cellulose or Elongivie. So there is no viscoelastic behind the lens at all. So instead of that, now I use this same forceps which I used to put it, and this becomes even faster now. Just use the same irrigation cannula to push the iris behind and pull it out. Even if sometimes this, you can see this pupil is slightly eccentric, so their chances of the lens may become slightly decentered, particularly it is very important. So don't have to do any enlarge the capsular axis because a lengthy might take more time cut with the scissor. Just give some nicks in the periphery so the effective axis is little more peripheral, that's it. So I take a 26 gauge needle, and wherever the axis is little smaller and covering the optics more than required, I take and make 4 or 5 punctures over there under the hydro infusion only, and I don't use again any viscoelastic inside the eye. A very simple procedure, does not take any time, because if I got to do enlarge this axis, then I put on a viscoelastic, cut with the scissor, then remove the axis, then remove the viscoelastic. So it takes 5-7 minutes. This is just 1 minute job, and your job is done. The effective axis will be that only. So why not visco? Saves the time and cost, decreases the post-op inflammation and IOP rise because there is no methyl cellulose inside the eye, decreases post-op toric IOL misalignment. Thank you very much for your kind attention.
Thank you, sir, for that wonderful presentation. In the beginning, sir, you showed the intralenticular massage, sir. When we do a ocular massage, the IOP decreases. But what is the physics behind how is the intralenticular pressure coming down by just doing a massage? Where is the fluid getting dispersed?
Whenever there is more pressure in the lens actually, so probably it works in 2 ways. One, there is uneven pressure in the lens. So once you do the massage, the pressure is uniform. Secondly, there are no pockets over there. If you see sometimes you see on a straight line, you will see the fluid pockets into the lens. Secondly, probably it relaxes and stretches the capsule a little bit. And I've done more than 100 cases and never had a single axis run out. And I make the large axis in one go. So initially I used to put on a viscoelastic, then used to massage it. So by the time I go for the axis, that the staining was very poor. So the visibility used to become poor. And then either then you put on a viscoelastic, do the massage, remove the viscoelastic, then stain the capsule. Because if the viscoelastic is there, the staining is not good. You can just drop some of the trypan blue over there, some visibility will be there under the methyl cellulose on top of the capsule, but ideal would be to remove the viscoelastic and then stain. So in this method, just do the massage with the hydrofluid going from this side, and you can stain as usual.
So all the things that we have been taught in intumescent cataract that make a neck, make a small rhexis, and all those things are not required once you do a massage?
Nothing. It has not been even a single instance where it has run away. And there is a patient with the glaucoma, with the total cornea edematous, nothing. And you could do a large rhexis in one go. Absolutely no problem. No problem.
Thank you, sir. Yes, please. Sir, can you take the mic, please? It's right there.
Sir, intraarticular pressure is related with the volume of the cortex, degenerated cortex inside the brain. And as you said, there are a few pockets of the fluid cortex. Then you massage it, and there is intraarticular pressure is reduced. So how it is possible? I don't understand.
So really, how it is possible, I really will not be able to answer because I have not done any study to find out the total volume of the fluid, whether it decreases or not, or whether some of the fluid leaks out. Because you will see that many times in an intumescent hypermature cataract, you will see the leaked fluid behind the posterior capsule lying into the vitreous cavity. So these capsules may not be as tight as we think, watertight. Maybe some of the fluid leaks from some of the areas. And but more important, probably the capsule itself gets stressed slightly and can accommodate more fluid. The tension which was there on the capsule has gone. So at least like when we do any massage anywhere, like we do the orbital massage, the orbital pressure reduces, some of the fluid is pushed out. When we do the massage, the vitreous volume is reduced immediately. You do the massage, ocular massage, the vitreous volume is reduced by 40%. So whatever may be the method, probably some scientist has to do. I'm more of a practitioner who practice whatever science I understand. So I have not done the study, but believe me, it works, and it works really beautifully well.
The fifth.
So that was a very helpful technique. My question is, have you ever faced an Argentinian flag sign while massaging?
No.
That was not.
So you have to have the irrigation cannula that way is very smooth, and if you take a rounded repulsor, that may be little thin, so it may get entangled somewhere. But this irrigation and aspiration cannulas are really very thick, so there are no chance of it's getting entangled anywhere. Because when you are moving the flap, so maybe there is a fold and you try to push it, it may rupture. But this is so thick that there is no chance.
Thank you, sir.